And now I'm going to turn it over to Micky, and I'll be happy to take questions at the end. I'm going to turn it over to Micky. He's going to talk a little bit more specifically than I can about sort of what's happening with applications and opportunities and challenges that they present.
Great. Thanks, Kate. Can you hear me?
Yes.
Yeah.
Great. Okay. Thank you. Thanks for that setup, and thanks to everyone, and welcome. So I'll just take maybe another 15 minutes to dive down specifically into some of the issues that Kate very nicely, I think, sort of teed up at that high level. Some of the topics will be the same, but I'll try to dive down to give you a little bit more feel for what's actually going on there, specifically as it relates to notes, which I know is near and dear to everyone's hearts here. And then at the end, talk a little bit about, as Kate pointed out, things are moving very fast. And in some ways, the technologies are actually moving out ahead of our policy infrastructure. And so that presents some challenges for us as well that I think it might be, both interesting and useful for all of you to be aware of as, you're out there in the field, thinking about these issues. Before I move to the next slide, Kate, was that really your blood pressure that you showed on the screen?
Yeah, that's really my blood pressure.
Wow. Don't stand up too fast. You might get dizzy. All right. Anyway, not to get into Kate's personal medical record here. All right. Next slide, please. So as Kate actually alluded to, the good news is that, patient portals are everywhere. And I think that, that if we sort of take stock of where we are, I think, that actually, as frustrating as patient portals can be sometimes, I think, it's kind of a remarkable achievement when you sort of put it in overall context. If you just think about, here we are in 2019, a short 10 years ago, as Kate pointed out, she got into all this area back in Bush 2, and then here we are. If we just look 10 years ago to when President Obama, I guess, was he had been in office for a year. So we're just talking about 10 years ago. Very few provider organizations had electronic health records. There were no patient portals to be found anywhere, right? There were some experimental things that, Boston Children's Hospital were doing and some other, places around the country, but patient access through electronic means in a routine way that could be, sort of accessible 24/7 to you and readily available was, in some ways almost unthinkable because most providers around the country didn't have the means to serve that information up to you electronically. So, I always like to just sort of remind ourselves and remind myself often that, we've actually have come very far in a very short period of time. As frustrating as these technologies are, at least like now we have this almost ubiquitous ability to be able to get electronic access to your medical record information or pieces of it. And, that's a challenge, obviously. It's not all of it, but pieces of it in some, sort of meaningful way. So that's the good news, right? Patient portals are everywhere, and they offer a wide variety of, kinds of functions, some of them administrative kind of functions like making appointments and prescription refills and paying your bills. And then some of them are about getting your information and communicating with your healthcare provider. And then, of course, the bad news of patient portals is that patient portals are everywhere as well. And, and what I mean by that is, one of the very frustrating things that people express sometimes is that they have to have multiple portals. So if you go across healthcare systems, you may be managing 3, 4, 5, patient portals. My father was ill a number of years ago, and we had to actively look at 4 different patient portals to be able to, sort of stay on top of all this electronic information. And on the one hand, it's a blessing because you're able to get it, but it does mean you're managing, that in 4 different portals, and each of them is portals, so you're not really, able to get the information the way you want. So, definitely some barriers there. And of course, notes were not really available, certainly not 4 years ago, and generally, aren't sort of uniformly available through these, these standards-based mechanisms that are now in place. Now, I will say before we talk about, the ability to download your records and, that ability, as, Kate showed in Apple Health Records, I will point out that we've had the ability to download health data for, for a number of years now. When those patient portals were introduced, there was the view, download, transmit requirement that many of you may be familiar with that term, VDT. And it required, the ONC rules required, ONC and CMS, ONC rules required that EHRs have a certified ability to allow a patient to access his or her information and to be able to do three things: view, download, or transmit that information. So it wasn't just a portal being able to see it on the screen. They were also required to provide the ability for you to download that data. And here I've just shown a screenshot of Athena Health's patient portal, and and there it is, right? You can download your health data. And now one of the challenges, a couple of the challenges of that we'll talk about were, one, that the formats weren't great, and they weren't necessarily compatible early on because they didn't sort of have a hard and fast kind of standard for how it got implemented. And you had things like the blue button that were downloading text files, and then you had things that were standards-based portals that were downloading these continuity of care documents, which were kind of clunky. And then you have the issue of it being this so-called continuity of care document. So now, Amanda, if you could please forward it. And so what that meant is that when you said download data, it was an all or nothing proposition. And so, Kate pointed out those data elements that used to be called the Common Clinical Data Set, the CCDS, as you see there. It's now called the US CDI. It's basically the same concept, which is there is a core set of data that is being specified by CMS and ONC that is required to be available in electronic health record systems, and that provider organizations who are taking who participate in Medicare or Medicaid are required to share that information that's being available, right? So it's just a core data set. You can just think of it as. And the challenge with the earlier portals was when you said download my data, it's great. You could get your data, but you got all of it. So even if all you wanted was your allergies or your medications, you got the entire file that had everything: your patient name, your gender, all of that. And that's a little bit clunky, right? For you as a person, an individual, that's a little bit clunky. But if you think about, sort of how we might want to scale all of this and say, well, how come I can't, sort of have apps or the kinds of nice, slick, clean, sort of functionality that I have when I go use the Home Depot app or use Uber and Lyft and OpenTable and all of these things? Well, one of the challenges was that all the data was locked into this construct, like this common clinical data set. So, let's say that you had an app that might manage asthma or diabetes or something, and let's say that you were able to download this data. The challenge is that you were downloading all of that data, and no app developer in the world wants to say, oh, well, I'll take all of that clunky data and parse it all and then figure out what data I need for my particular app, and then we'll be off and running, right? No one was interested in that. App developers just saw that as being incredibly clunky. These are standards that were created in the 1980s and very hard to scale. So as a result, to the extent that people were even interested in working in this, they were all healthcare people. You didn't have people from outside the industry who were willing to jump in because they saw this as kind of backward, clunky, and really just too hard to deal with, even though there can be a lot of value in, both monetarily, but also in terms of people's lives, right? We're talking about healthcare as opposed to, taxi service or whatever it is. So that was a big barrier. Now we'll move to, where we are today. And I'm going to give you a little bit of an example from, sort of outside of healthcare, just to give you an intuitive sense of what is it we're talking about here. As Kate mentioned, I think she alluded to, these apps are now based on modern internet conventions. And I just want to give you a little bit of a taste of what that means so that when you walk away and someone says fire, you actually have some basic understanding of what that is. You're obviously not expecting that everyone's a fire developer, and I myself am not a fire developer, but just to give you an intuitive sense in another walk of life of what we're talking about here, and to give you a sense that, oh, okay, this is exactly what I'm familiar with, and outside of healthcare, and now it's finally coming to healthcare. So this is a snapshot of the Sears Roebuck website from 1997. Believe it or not, it's still available. You can go find it on the Internet Archive for anyone who's interested in looking at old websites. It's like going through a museum, but you can go into the Internet Archive and you can just find old websites, going all the way back to the beginning of the World Wide Web. And so I dug this one out, and this is from the Sears website. And if you were going to place an order at that time, let's say you wanted to buy a lawnmower or a dress or something, what would you do? You would go and you would click on one of those icons there on the left, all right, that show, sort of those covers. And what would actually happen on your computer is, and some of you may remember this, is it would actually download the Sears catalog onto your computer. And of course, we were using those old modems back then, so it took like, 20 minutes and all the beeping and the hissing and, all those sounds that some of you may remember. But it would actually literally download the whole Sears catalog onto your computer, and then you would electronically flip through, and then you'd come back onto this website and you'd type in, Craftsman lawnmower. It's on page 543 of your 1997 catalog, and then you type in the catalog number and and the price and blah blah blah, and then you'd hit put it in the shopping basket, and I don't know what happened then. I mean, maybe it just said call us, but but the point is that it would download the whole catalog, and then you had to do all the work of figuring out where that lawnmower is and all of that. And I would just submit that that's kind of like the continuity of care document I was just showing you before, right? You just wanted to know your medications, or an app just wanted to know your medications, and it responded by saying, here's everything, and you figure it out. You figure out what you need. And in the same way, you go into the Sears website, and it says, here's the catalog, you figure it out. And then you come back and tell us exactly what you want. And if you can think about, sort of project ourselves forward, right, with that kind of architecture and infrastructure, of course we didn't have pricing, websites, right? Because how could a pricing website go onto the JCPenney, Kmart, Walmart sites and download all those catalogs and then parse all of that and then create a nice user experience so that you could say, I'm looking for lawnmowers and look at lawnmowers across all those sites, right? It was a real barrier. We wouldn't have had the technology to be able to do that. And that was the same, sort of battle we were fighting back then, and that's the battle that we're fighting right now with the continuity of care document, that with that structure, you can't do it in the same way that the modern internet works. So now let's take a modern example. Here's, the example that almost everyone on the phone, I'm sure, is very used to, and in my case, multiple times a day, unfortunately. But here you are on the Amazon site, and let's say you decide, so first off, as all of you know, if you click on one of these things and say, gee, I'd like to get, Lauryn Hill's Miseducation of Lauryn Hill album, or I want to be able to get, One Mississippi Season 2, whatever it is, Amazon doesn't come back and give you the whole catalog, right? They give you exactly the information you asked for. It says, here is One Mississippi, right? Here's here's her Season 2 of One Mississippi. And so similarly, if we hit the next slide, please, Amanda, what happens when you say, I want the Miseducation of Lauryn Hill, as all of you know, you now get, here's the album, right? And then further, if you clicked in and you said, I want to hear To Zion, then you click on To Zion and you get it. And what happened when you did that, right? And I'm sure, most people don't pay attention to, well, what happened when I clicked on that? You're just paying attention to what you get back. But if you look up in that browser window, there's all this gobbledygook up there that no one, including me, understands what that means. That's actually the code that's a request. It's the query that goes to Amazon that says, Amanda or Kate just wants to hear To Zion by Lauryn Hill. And please send that back, right? It's a query and it's a response. And it gives just that information back. What I have just shown you is how FHIR works, right? That's exactly how FHIR works. It's what's called a RESTful API. You don't need to remember that term if you don't want to, but the point is that in the same way that Amazon works and Facebook works and every other website that you go on, it all happens in that little browser window through this kind of coding and through this kind of communication back and forth between systems. With FHIR, we're able to say, that's how we want healthcare to work. That's why we want electronic health records to make this data available in this way so that I can take my app and instead of getting the whole darn Sears catalog or getting the whole darn continuity of care document, I can just say, just give me the medication. That's all I want. And it'll do it behind the scenes using the same exact kind of paradigm as I've shown you here. And it's literally the same thing. It's just modified a little bit for healthcare, because of course in healthcare we have sort of special requirements that go beyond what you need for searching for record albums or electronic music on a website. So that's kind of what we've lived with the internet, and that's what's given us the world of apps today. So the question is, how do we get that to healthcare now? Now we're impatient, right? It's like, I don't want to wait for this anymore. I want this in healthcare. And that brings us to HL7 FHIR. HL7 FHIR is basically saying, let's take that standard, that RESTful API approach, and now let's apply it to healthcare. And we'll give it some of the special ingredients that it needs for healthcare, but it's basically that same kind of concept in the background. So what's so great about FHIR then? Well, I've already talked about a couple of things, but just to make them very explicit. One is it's flexible to document level and data level exchange. Well, what the heck does that mean? It's just what I was describing, that I can get the whole document if I want, because as many of you may know, in clinical care in particular, sometimes you do want the whole document because the whole document tells the whole story. Well, right now it doesn't have the notes in it, so you could argue maybe it doesn't, but at least it gives you a picture of that encounter. Let's say if it's an encounter level, a document like a discharge summary, it gives you the overall context. Whereas sometimes you just want the data, right? Sometimes you do want the context. Sometimes you just want to say, I don't care about what happened in the whole encounter. I just want to know what their most recent medications were. And so it allows you to do either of those things. It's also, as we just described, right, it's based on modern internet conventions. So it basically says it's a RESTful API, it's very lightweight, and it's leveraging all of the experience we've had now in other parts of, of the economy that we can now bring to bear in healthcare. And finally, what all of that does at the end of the day is it makes healthcare and healthcare IT in particular attractive to developers from outside of healthcare. And I think that's been part of the problem with health IT, is that because we've been using these standards and these approaches, which are both very specific and peculiar in some ways to healthcare, but also old, based as I was describing to you before, the continuity of care document is really an old standard, and it's based on things that were developed in the 1980s with very cumbersome implementation guides and the kind of thing that you would never get, a new RPI or, MIT or Stanford grad to pay any attention to if they were going to be a developer, right? And that's the last thing in the world they want to be doing. Now we're basing it on these RESTful APIs, which are very much like the kinds of standards and the kinds of implementations that happen outside of healthcare. And that's why you're seeing all these organizations now jumping in. And as Keith showed before, that slide with Salesforce and Oracle and Microsoft and Amazon, all of them are looking at that. And that's why they specifically said, we're all about interoperability. And we like FHIR and we like the Argonaut project. Why? Because it's something they're very familiar with. They're able to look at it and say, finally, they're doing something in a way that we understand, because it's the way that we do everything else, outside of healthcare. And I think that's a really big boon to the industry. It's got its challenges, as we'll talk about in a second. But one of the things that's really good is it brings fresh thinking, fresh blood, fresh DNA into the healthcare space to really let us think creatively about how do we enrich this as a consumer experience that puts patients and consumers more at the center of things if they want to be. Right? And I think there's still an open question, and there at least is in my mind, of how much every patient wants to be at the center of, so many things involved, related to their healthcare delivery. But I think that all of us would agree that they need to have the opportunity, and that for those who do want to, they need to have the opportunity to have all their data and all the tools available to them that we can offer. So that's why FHIR is so great, and hopefully that gives you a good intuitive understanding of what are we talking about when we're talking about FHIR. Obviously, what I haven't talked about is the opportunity for apps, right? And why are apps important? The beautiful experience of apps is, and you may not have sort of thought about it specifically, but I know you live it every day, because I'm sure every single one of you, or almost every one of you, has a smartphone and has downloaded some apps onto your phone. And what do apps do? They're using the same standards in the background. So apps aren't using any different standards than that website depiction I showed you before between on the Amazon website. But what an app does is it really gives you a much more focused and personalized experience than being stuck on a web page. Right? Web pages, if you open up Chrome or you open up Internet Explorer or Firefox, as you can do a bunch of things, but you're still stuck within that browser. Right, and you're limited in what you can do by what the browser allows you to do, and that's why you start to see so many apps where people say, these vendors say, here, we're going to give you an app, and then we can control the whole experience and make it a much richer experience for those who want that kind of experience. And that's why you have these very focused, tailored kind of apps on your phone that really speak to you, right? And I've got some apps that I just love. I use them every single day, and they really speak to me, and they really help me guide my life in the way I want it to. And Kate's phone looks different, and Amanda's looks different, and all of yours look different based on that, sort of set of apps. And so you can imagine that in healthcare more than any other place, right, people have that kind of diversity and that kind of different levels of engagement with different types of things based on their conditions, based on their preferences, whatever it is. And so that's the other beautiful thing, I think, that that FHIR starts to enable is apps. And as Kate pointed out, the availability in the iPhone now starts to say that's where you start to open up that app market and the app opportunities for that. So who is behind this Argonaut project? I just want to give you a feel for, for the organizations behind it. I'm the manager of the Argonaut project, but it's really driven by this set of technology vendors and these provider organizations who constitute the sponsors of the Argonaut project. As Kate said, it's a completely private sector initiative. It's paid for by these organizations who just put in a certain amount of money every year and just say, what are the next set of things that we think are important to the industry, that we're hearing from our customers, that we're hearing from patients, that we're hearing from the federal government, that we're hearing from, any sort of channel that we can get at. And then how should we sort of focus the money that we have in any given year on a set of things that we think are important. And as Kate described, last year we focused on clinical notes because we were hearing that was going to become well, there are two things. One was we were hearing that was going to become a part of this US CDI. So ONC was starting to say, gee, it would be, we're thinking of adding clinical notes to that, but the standards aren't well developed enough yet. It would be nice if those got more well developed. And then also we were hearing it from the market, right? From providers saying to us, the continuity of care document, it's got some valuable information in it. That's great, but it doesn't have the notes. And the notes are what tells the story. And I told Kate and Amanda the story, I think, but I'll just give a little short vignette of that. My mother is a physician, and she's in her 80s. She had an encounter at Partners, and I signed her up for Patient Gateway. And then we came back, we set up a portal and, did all of that, went through the registration, set it up. And I said, well, here's your record. And she got on and she looked at it and, she saw her lab, she saw her meds, blah, blah, blah. And she said, yeah, but where's the record? And I said, well, it's right there. Look, there's your labs, there's your meds, there's your problems. And she's like, those are just results. That's not the record. Where's the note? And I said, oh, well, the notes aren't available yet. And she said, well, no. She's like, that's not a record. A record has the notes. So anyway, that just to give you that sort of personal story, that's what we were hearing from providers, is the notes have to be a part of this. It has to be a part of it for us, and it has to be a part of it for the patients as well. So that was the other reason that we decided we were going to focus on, on accelerating the availability of clinical notes. And that now is a part of the US CDI, as Kate pointed out. So as we discussed, Apple was a part of the Argonaut project, and so one of the things that they did when the Argonaut project created that implementation guide, that first specification for data query, as it's called, is Apple said, we're going to bake that into our iPhone. So we're not going to use a proprietary Apple standard. What we're going to do is use this open standard that was created by this open collaboration, and we'll use that as the specification for, what we're going to put into the iPhone. And, I think it's been tremendous in many, many ways. And, one of the things I think that it really points to as you think about, sort of what I was describing of people coming in from the outside of healthcare and the ability of FHIR to offer information in a way that people find a little bit more useful and therefore we may get more adoption of, is that, before, as I pointed out, you could download your medical record for the last 4 or 5 years on most patient portals. You could download your medical record. Very, very few people did that. Very few. In the single-digit percents, we're doing that. And you didn't see provider organizations eagerly pushing that. I mean, they were pushing their portals, but they weren't pushing the ability to download your record. And what happened when Apple made this announcement? They had a huge surge of CIOs and CEOs of hospitals from across the country calling them, asking when they could get in the queue to get the integration of the iPhone. We'll see in terms of, what the actual usage of it is. Because right now, as we know, right now the data is just available on your phone. We don't yet have a rich set of apps that you can take that data with and use, and do good things with it. And obviously just having the records in your phone, that's not valuable to anyone, right? But it's when you get apps that are able to access that data and do things that are important to you. If you have diabetes or you have, a heart condition or whatever it is, that's where the data and the ability to have it on your phone becomes really important. So that's the part where right in the transition here where you're able to download your records, but now we need to have that app, sort of that app economy develop. And just yesterday, or it might have been this morning, I'm not sure which, Apple announced that they've opened up the development platform for apps that want to access the Apple Health record on the phone for organizations to start testing, so that they can start to get certified to get access to medical records on the iPhone with your permission. So we're now sort of at the beginning of that second partner where Apple has said, all right, it took us a year to understand how do we get the technology in place using these open standards, get it into production systems so that we know it works in terms of a patient being able to get on and have a relatively seamless experience of identifying, as Kate showed that screenshot before, my data's at Partners, my data's at, at Northampton, Medical Associates, whatever it is, and then being able to download that. And I said, all right, great. Now we know that works, and now we're going to open up the development side of this, the platform side of this, so that app developers can now come in and we can work with them on figuring out how do we create the healthcare section of the App Store for them to be able to make those apps available to iPhone customers. We don't yet have an Android side of this, which is somewhat frustrating to me because I'm an Android user. But be that as it may, I think it's going to come soon. But obviously Apple is hugely important in this and is helping to push all of this forward. So one of the things that now that is enabled is that now that technology is available, right? And that's been a lot of hard work. That's been 4, 5, 6 years. I mean, it's more than that. But if you think about Fire and getting all the hard work of making Fire now as something that is based on modern internet conventions, adapting it for healthcare, getting it to a level of maturity that we can now start to say that, okay, now it's going to be implemented in electronic health record systems, regardless of which system. It's going to be an open standard. And then Apple picks it up, puts it into, the most ubiquitous consumer-facing technology in the world, namely the iPhone. So now, that's all happened in a relatively short period of time. And now that that's all in place, the federal government is able to say, all right, now the technology is available. Now we're going to use these policy levers we have to make patient access, sort of front and center in the way we think about all of this. And so as, I think Kate, described, you've got these 2 rules which are implementations of the 21st Century Cures Act. So you had that law that passed in 2016, right in December of 2016, which is 21st Century Cures. And now, it's taken a while. So there's been a lot of frustration among a number of people, me included, that it's taken them, 2.5 years to get the rules written for a law that was passed in December 2016. But I'm not going to complain because they're out there now. So these are the draft rules that should be finalized before the end of the calendar year. And they have, kind of 2 arms. One is the ONC rule, which points directly at creating a standard based on Fire APIs for making data available to patients via and that U.S. Common Data for Interoperability, the U.S. CDI, which includes clinical notes. So now clinical notes have to be a part of that core package that's available to to patients and providers, and it actually has real fines for providers and vendors who violate any of these rules. And then equally important from a patient perspective is the CMS rule, which kind of came out of the blue because the 21st Century Cures Act did not require it. But it basically was CMS saying, well, we believe this is really important as well, and patient access is really important. And so we're going to put sort of a parallel rule into place, which basically says, well, we've been doing all of this stuff but we've been doing all this stuff to providers, pushing providers to adopt this technology and to start making this data available to patients. Now we're going to say, you know what, if you're on the payer side, you have to do the same thing, because payers have information that patients want access to. And payers have to share information payer to payer because patients go from payer to payer, in our healthcare system, just like patients go from provider to provider. So payers ought to be required to share that information. And, oh, by the way, you have to use the same Fire APIs that the providers are required to use so that when we're in the position of payers and providers exchanging information, we're using the same specifications and not doing what we have today, which is you have a whole set of standards that are used for payments, which is X12 and EDI transactions, and then you have a whole different set of standards that's used for clinical data interoperability. CMS is basically saying, we want this all to be brought together, all, sort of in the interest of patient access at the end of the day. So when you read those rules, and I'm not sure how I would recommend, there's 900 pages of it, but the preambles to the rules are actually very interesting because they tell a story, and that story is a story about patient access. That's really what they're focusing on. So here's my last slide. And this is where I just want to describe for a second how technology is outpacing policy. And that's just a challenge for all of us. I don't mean to suggest, and I'm not suggesting that this means that we should stop, or this means that patient access is a bad thing, because I think patient access is a very, very good thing. But I do also want to point out and feel obligated to point out that we are a little bit in this transition mode where things are a little bit scary in certain ways, and that, I think it's really important for all of you to just understand that, and to understand that we need our policy infrastructure to catch up with where our technology is right now. So here's, a pop quiz. And if I was in a live setting, I would actually ask you to raise your hands and tell me. But the pop quiz is, here are two representations of your patient record. On the left-hand side is one representation of a patient record on a smartphone, and on the right-hand side is another representation of your record on your iPhone. So let's just pretend that, you could have had either of those, right? And the question is, which one of these is protected by HIPAA? And it's not a trick. I mean, I guess we could argue about whether it's a trick question. It's not a trick question, because one of them is, it turns out, and one of them isn't. And the one on the left is the iPhone Apple Health Record that we talked about before, where you're downloading your record onto your iPhone. The one on the right is the Epic MyChart app, and that could be any EHR app. It's not just Epic, but I just took a screenshot. I took a publicly available screenshot from an Epic MyChart, which is what I have on my phone, and that's the app. Turns out that is protected by HIPAA. And so first off, why is that? Well, for a very, very simple reason that most 99.9% of individuals, patients out there will not appreciate, which is that the one on the left-hand side, my records are physically now in my phone, right? I have actually downloaded those records onto my phone, and that's the way the Apple Health Record works, is it goes and gets your data and brings it onto your phone. The minute you did that, you have gone over the HIPAA wall, and you're now on the other side of it. And you may not have realized it. Now, I think Apple does a lot to try to tell you that, but there's no law that tells them they have to. And you're now on the other side of it. And those records that are now in your possession are outside of HIPAA protection. Whereas the one on the right is an app. And that's, in this case, it's the Epic MyChart app. And that's absolutely covered by HIPAA. Why? Because it's an application that is making the data available for you to see, but it's not downloading it on your phone. And furthermore, it's an application being provided to you by a provider organization, which is a covered entity, which is definitely covered by HIPAA, right? And I think, as most of you probably appreciate, the confusion that most individuals have in their minds is that they think that HIPAA covers the type of information, meaning, well, if it's medical record information, it must be protected by HIPAA. That's not true. If it's medical record info, the HIPAA only covers the organization that is the steward of the information. It doesn't cover the information. Apple is not a covered entity. A provider organization is a covered entity, and Epic or Athena Health or whoever is their business associate. So all of them covered by HIPAA. So why is this important? The reason it's important is that the one on the left-hand side, the Apple Health Record, as I described before, we're not going to have a world where apps can access those records. Let's just say, and I just want to point out here that I think that Apple is actually being a very good steward around this, and they have built in all sorts of protections so that you as a patient it would be hard for you to accidentally give access to an outside app to your health record. But we know lots of things happen in the real world, and we also know that there are lots of other vendors who could implement this, and they're not going to be as diligent as Apple is around it. And just imagine, just like all of you do today, because I know I do, you download an app, it does something, whatever it is, diabetes, whatever, and you just click through, and say, yes, 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 you have permission for this, yes, 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 just get me to the app. And one of those permissions allows access to the records. In some cases, you may have wanted that, right? It's a diabetes app. Of course, I want to have access to my record. That's a great thing. What if instead you downloaded OpenTable? And OpenTable says, hey, I see that you've got records on your app. And wouldn't it be great if we had access to your food allergies? So the next time you make a reservation, you don't have to deal with this at the restaurant. We'll just tell the restaurant, hey, so-and-so has, these food allergies, gluten, whatever it is. And at that point, if OpenTable does access your records and you've given them permission to, inadvertently perhaps, or advertently, because we always sacrifice privacy for convenience, right? That's how we use Gmail today, and that's inherently not private. At that point, that data is not protected by HIPAA at all. So OpenTable could literally take that data and do whatever they want with it. They could sell it. They could openly sell it. They could do anything, and HIPAA does not protect that information. And in a world where prior conditions are seriously at risk in health insurance, you could imagine that that is a bad decision that you made, perhaps by accident, that could follow you for the rest of your life because your records have now been exposed to a technology vendor that is not covered by HIPAA and is able to do whatever they want with that data. Now, in California, they have a data protection law. In Europe, of course, they have a protection law now that I think many of us are familiar with that would cover that kind of thing with HIPAA-type safeguards, regardless of who is in possession of the data. But that's a really important thing, I think, for all of us to understand right now, is that we're living a little bit in this world where we've got this gap, that we're putting information in the hands of patients, and they may not appreciate the risk that they face when they do it one way versus another way, and that the risk that they face in sort of trading a little bit of privacy for a little bit of convenience, which is what we do every day with these apps, may actually come back and bite them in ways that they don't fully appreciate with their health record information.